welcome everyone. Thank you everyone who have responded to our poll. We should be sharing the results with you. So again, I'm Ankit Sangvi. I'm the Executive Director with the Texas Health Institute and have the honor and privilege to serve as the co-lead for the Texas Primary Care Consortium. Again, welcoming everyone for our second webinar in our series at the consortium titled Powering Primary Care Advocacy, featuring the Milbank Memorial Fund. Truly excited and looking forward to today's discussion. But before I hand it off to our speakers, I wanted to take this opportunity to recognize our partners at the Texas Academy of Family Physicians and Texas Medical Association for their support and helping us host today's webinar. I also want to take this opportunity to thank all of our partners for the consortium in helping with the growth and sustainability and all of our work that we get to do every single day through the Texas Primary Care Consortium. For those of you who are not familiar with TPCC, it's a statewide collaborative initiative with a mission of advancing equitable, comprehensive, and sustainable primary care for all Texans, and is jointly led by Texas Medical Home Initiative with the Texas Health Institute. It's been a journey that has evolved significantly over the last 11 years, beginning with the annual Texas Primary Care and Health Home Summit, which culminated and really took the shape of the consortium back in 2019. And it's been an exciting journey to be a part of. Our work at the consortium, as we often refer to that as a theory of change, is we are hoping to move the needle on primary care and work towards our achieving our mission by a three-pronged approach of educating and creating awareness across all stakeholder groups, activating a network approach for moving the needle and bringing systemic change for primary care in Texas, and advancing opportunities or strategies that create space for dialogue and action to transform our systems through policy and systems change initiatives, again, with the ultimate goal of advancing access to comprehensive, sustainable, and equitable primary care for all Texans. And this webinar today is a step in that direction, and I'm truly excited to have our colleagues at the Milbank Memorial Fund join us today. And with this, I want to take the opportunity to introduce my friend and our colleague, Dr. Sue Bonstein, Executive Director with the Texas Medical Home Initiative, to set the context for today's webinar and introduce our esteemed panel of speakers.
Thank you so much, Ankit, and thank you for all who are joining us today. We really have been looking forward to this conversation with Chris Kohler and Lisa Watkins ever since we had our first conversation with them to plan it. We feel that this really follows very nicely to our first webinar, which Dr. Jackson Griggs led and really shared with us an in-depth overview of the primary care report from the National Academies. I should also just happen to mention that Chris Kohler was one of the authors as well. He was on the writing committee. So you will hear some more about that today. But Chris and Lisa are going to help us really further our understanding of how we can take the lessons learned from the NASM report, as well as the lessons that they have learned over the years in their different capacities to really further primary care transformation. And they're going to share with us some examples of how other states have been successful in doing this. And so we are very excited to hear from them. And I want to just briefly introduce them, because really what we want to do is hear from them. I can tell you, though, I just have to say this, that I've been is it okay to say fangirl if I'm in my 60s? I guess it is okay. I've been a fangirl of Chris Kohler since I first learned of him. And he was then the health insurance commissioner for the state of Rhode Island. And many of you who have been following this PCMH primary care transformation journey know Chris, you know his work, you know that he really has been one of the leading forces, thought leaders, and people that really can make things happen. And during his term as health insurance commissioner, he did in fact make things happen. He was really one of the first to embrace the patient-centered medical home, and his state did a lot of really important foundational work for the PCMH. As Ankit said, Chris is now the president of the Milbank Memorial Fund, and I think they have a slide, so I won't go too much into Milbank, but it is certainly a very important institution in our country in terms of healthcare, primary care in particular. Again, Chris is a leading force for primary care transformation and delivery system transformation. And his colleague, Lisa Watkins, Dr. Watkins, is the director and one of the founding members of the Milbank Memorial Fund primary care, multi-payer primary care network. This is a consortium of about 18 state and regional multi-payer programs designed to transform primary care. Dr. Watkins is a pediatrician. She's a board certified pediatrician who practiced in Vermont. And she also has served as previously as the chief operating officer for the Vermont Blueprint for Health, which is, again, has been one of the leading really thought engines, if you will, for primary care transformation. So we're just thrilled to have Chris and Lisa here with us today. And we really are looking forward to a very rich discussion. So Chris and Lisa, it's yours.
I think that's our cue. So let me make sure we got the screen. Okay, folks see a full screen there?
Looks good.
Great. Okay, so thank you very much, Sue. I'm gonna hand it to Lisa in a moment, but just the fandom is mutual. Want to congratulate Sue. I did it privately, but do it publicly for her really well-earned award from the Primary Care Collaborative, the Barbara Starfield Award. This goes to people who have advanced the cause of primary care. Sometimes, Sue, a prophet is not honored in their own land, so I want to make sure the folks in Texas realize the respect with which you're held nationally. With that, Lisa, do you want to go ahead and start us off here?
Absolutely, and thank you everyone for this opportunity to address this at the TPCC meeting today. We're delighted to be part of it. Just some very brief information about the Milbank Memorial Fund. It is an over 100-year-old institution of philanthropy based in New York City. We are an endowed operating foundation, and our focus is to improve population health by connecting leaders and decision makers with the best available evidence and experience. And our work is really advanced by identifying and inspiring, hopefully, health policy leaders to make the hard decisions they have to with perilously small amounts of resources, working with state health policy decision makers on issues that they identify as important. And those include currently our areas of focus around primary care transformation, sustainable healthcare costs, and aging. And then, of course, we have what we think is a pretty noisy footprint for a small organization around publishing high quality evidence-based information through the Milbank Quarterly, which is a peer-reviewed periodical, and through our own website. Next slide, please. So in thinking about what we wanted to share with you today, and certainly take part in a conversation back and forth, looking forward to that part of it, we want to identify what the problem is and help that discussion move that forward, because sometimes it can seem overwhelming in its massiveness, but there are ways to pare it down. We want to certainly just share with you aspects of the 2021 NASM report, and which really we think made a very strong case for primary care, and specifically for primary care transformation. We want to talk about primary care spending strategy and share with you what we know about the experience of other states around the country. We know that there's a very strong advocacy arm, especially in this group today, and we want to talk about some of the things that we've seen that are successful in other places. Point you to what we think are the key policy questions, and then trying to apply this to the work that you have to do moving forward in Texas. Next slide, please. So I'm going to hand this over to Chris with the next slide, but just wanted to really focus on why are we doing this? What is primary care from our perspective? It is only part of a healthcare system that results in longer lives and more equity, but it is a very important part. And there's increasing evidence, and some that was just published this week, about primary care oriented delivery systems being able to identify a usual source of care, for example, that can generate better health outcomes and lower disparity rates. Unfortunately, primary care is certainly under duress at the moment. The events of the pandemic just tanked primary care's ability to keep the heads above the water for a very long period, from the perspective of the people who are trying to take care of patients and from patients' perspective. And we really need to address that in this critical time. And we do think that ultimately that the dollars and make sense, but this is not a quick fix. This is something in the long run, which doesn't make you popular when you say it's going to be a long time before you see real evidence of cost savings and more rational expenditures. But we believe that to be true, and we believe it's important to be persistent and patient. Next slide. Okay, Chris, I'm going to hand this over to you. As Sue mentioned, Chris was one of the authors of this report that came out in May, and we've been very busy sharing it with a lot of our colleagues and looking forward to doing that with you today.
So thank you, Lisa. And since you had Jackson talk about this previously, we won't spend a lot of time on it. I do want to note it was an honor to work with the committee and a real pleasure to work with Jackson. He would describe the stuff that he's doing in Waco, and particularly in the middle of the pandemic, and the way he worked so hand in glove with Waco Public Health. It really a model. I think his health center is a model of the role that primary care can and should serve in a community. So where we began was just this definition of high quality primary care. What do we mean? Just because you're a primary care doc does not mean that you're doing God's work. There is an aspiration here for primary care. The definition that the committee came up with, which I'm sure Jackson reviewed with you, is this one. I just want to call out the attributes of it: whole person, integrated, accessible, and equitable. The fact that it's provided by teams, not by a clinician, and that those teams are accountable for the majority of individuals' health and wellness needs across settings. So no longer between 9 and 12 in the morning and 1 and 4 in the afternoon when the doctor is in, and through sustained relationships with patients' families, not a convenience care at the end of the day, but through sustained relationships over time. So this is really sort of the high quality primary care that we are seeking to build here. Key point is, if we're going to define primary care that way, if its value is improving lifespans and reducing inequities, that means that it is a common good as opposed to a service that available for private transactions. And we bit the bullet on that as the committee. That isn't necessarily a super popular place, when we want to have the market solve everything. But if the main attributes of primary care are that it improves lifespan of a community and that it reduces equity, that makes it a common good, as opposed to something that you invest in now so that it can save money in a few years. But that means that if it's a common good, it requires public policy to steward. And that's why we're talking about these policy strategies today. This is our punchline: the 5 main action areas that we need to work on, we think, to implement the high quality primary care that's in that definition. It's no accident that we put payment first, and close behind it is this notion of access. We also have to work on the workforce. What was new and not appreciated is the role of technology and the importance of digital health. And then finally, if it is a system, we have to think about how to hold it accountable and to do research and development going forward. So I'm sure Jackson talked about the details. That's not what we're going to get into today, but I've been pleased at both these actions and then the specific activities beneath it are relatively robust. As we've talked about this, there are rules for Medicare, there's rules for Medicaid, for private payers, for providers, for consumers, and that's really what you need when you're working on a system problem like this. And so the major takeaways, I don't know how Jackson framed this for you, is that high quality primary care is a common good, which requires public policy to steward it. It is fragile and weakening. We may feel like we're fighting the good fight, but we have to acknowledge that the portion of primary care, the dollars that are going to primary care, is decreasing, and that just a report that came out this week in JAMA for Medicare patients with chronic illnesses, the ones who could benefit most from primary care, fewer are approaching a usual source, are reporting a usual source of care between 2010 and 2016, in spite of all of our best efforts. So this notion of a usual source of care becomes really important. And then finally, you got to focus on the payment, and the fee-for-service treadmill is really damaging. So with that in mind, let's talk a little bit about how we create a public focus on primary care, which is really, when we talk about powering, that's a tough gerund, Ankit, powering primary care advocacy. That's creating, what we're trying to do is create a public focus on primary care. And that means that we've got to build public will for public oversight, that we've got to make this a priority for officials and other stakeholders, payers, providers, but primarily public officials. It means that we're not going to innovate or compete our way to strong primary care for everybody. And the prevailing cultural trend is that innovation and competition will save everything. And we don't think that's going to work for primary care. And there certainly are places for it, but we don't innovate and compete our way to strong education systems for everybody. There's a fundamental commitment that we make to having education available to all. Same thing with public health. And public policy is important. Healthcare is not a market, and the strong players in healthcare got that way by commanding favorable public policy. You can look at the advantages that specialists have in Medicare, how pharma gets protection with patent laws, the hospital's response in a time of COVID, and the way that they commandeered so much money. So if we're serious about primary care advocacy, we've got to play in the public policy game and know how to build public will for it. We think that a key way to do that is to focus on this notion of primary care spending rate. We also call it a primary care investment rate. We have not hired a public relations firm, so we kind of vary back and forth in terms of what we should call it. But it is this math up here. The amount of money that a system, a health plan, a state, a Medicaid agency spends on primary care relative to all the spending that they do. And we think that that's really important as a way to educate and focus public attention. When I was health insurance commissioner, I would routinely ask employers what portion of their premium goes to primary care. And to your guys' credit, if you're a primary care advocate, they all thought it was way more than what it was. They would say 15, 20, 25%. They would never say, and they were shocked when the answer was 5 to 7%. So just as a way to educate folks about the paltry amount that goes to primary care when they think it is so valuable and so important, there's a bit of a shock effect there. We use the slide in the National Academy of Medicine to show portion of spending in the green versus portion of activity. That sort of carries out this. And we think that primary care spend, it also gets to dollars, because if you're going to change that, it's not only an education tool, but it's a way to measure progress. The other measures that we often see around primary care, staffing ratios, don't attract the same comprehension by folks who are trying to get to our side. PCP salaries, you're not going to win any sympathy there, given it's only primary care physicians care that they're not paid as much as specialists. The rest of the public isn't too sympathetic to that. And the access to care is important from a population health standpoint, but doesn't command people's attention the way that the primary care spending rate does. I want to talk a little bit about where Texas is relative to that. And this is data from the Commonwealth Fund. We've been working with them to collect and produce this information. I'd say the commercial data, they do it for commercial and Medicare. We're working on it now for Medicaid. The commercial data doesn't capture the non-fee-for-service spend. Medicare tends to, so I think the Medicare data is a little bit more reliable. And you can see that Texas is in the middle of the pack if you think in terms of terciles relative to the rest of the states. If you look at your neighbors, this is from the same Commonwealth Fund data, it's just that we broke it down more. Texas is over next to the right at 5.5% of Medicare spending going to primary care. Compared to your neighbors, you're slightly below the US average, and you're on the low side relative to folks in the South and Southwest. You've got, and no particular surprise to folks on the call, this arrow points to the olive green. This is the portion of adults who report not having a personal doctor or healthcare provider. So high is bad here. You've got continual concerns with that, particularly relative to the US average. That's a function not only of primary care availability, but also insurance availability, obviously. So there's a usual source of care can not only be solved by primary care advocacy. Obviously, there's insurance coverage issues to deal with as well. And finally, HRSA, the Health Resources and Services Administration, looks at health professional shortage areas. This is actually relatively good news. See, they define health professional shortage areas, and darker is better here. The darker it is, the more that you have your need met, the less of a hill you have to climb. And you can see that Texas, relatively speaking, in its HPSAs, has, relatively speaking, more of its need met than some of the other places. So you've got primary care challenges in Texas, but they are solvable relative to other places. What can we learn about state level advocacy? Healthcare is a mix of federal and state work, but important for the fund is the notion that with states having Medicaid levers, having commercial levers, having legislative levers, there are things that can be done at the state level. Yes, Medicare has to think about how they pay for primary care, but states don't have to wait for Medicare to change. And so the Primary Care Collaborative has been tracking states with legislative activity around primary care spending. There could be, what we've got here is the states that have done some sort of a state report, or no, they've had legislative laws and regulation. There are also states that are reporting out without doing legislation, laws, and regulation. But this is states with legislation, laws, or regulation. And you can see a pretty wide spread of states that have gotten their legislators or their governors concerned enough about the state of primary care to act on primary care spending in particular. We want to go to 3 states and just give some examples of how they've done it. Oregon didn't start with primary care spending. They actually started with patient-centered medical homes. They called it their patient-centered primary care program. And they've been at that for 11 or 12 years, going back to in their Medicaid agency to have a Medicaid-sponsored patient-centered medical home program. When they advanced Medicaid managed care, they instituted that medical home requirement. And then 4 years ago, they really bit the bullet around primary care spending in particular. So they built on a Medicaid commitment to primary care and patient-centered medical homes to rope Medicaid, Medicare, and commercial payers larger into this primary care spending rate requirement. The Oregon Health Authority captures that information. They use their all-payer claims database, and they report annually to assess how, and they name plans, they name names to report how they're doing. And you've got a link here if you want to see the report that comes out annually. Colorado took a slightly different approach. They had been doing multi-payer payment reform for a while. And in 2019, they passed legislation actually focused not on Medicaid, but on the Department of Insurance. The 2 key parts of this were percentage of medical expenses allocated to primary care by insurers, so that primary care spend requirement, a report on that, and then the establishment of a primary care collaborative. I'm going to talk about that a little bit later, that is run by the insurance commissioner, looks at the report every year, and makes recommendations back to the legislature about this best practices and technical assistance. So you can see there starts to be a pattern here. There's work on a medical home, then there is some legislative engagement in a primary care spend strategy, and some sort of a clearing group that looks at it and maintains focus year over year on it. Washington did much the same thing. I'd say they're a little bit behind Colorado. They're working right now on a Medicaid all-payer payment reform for primary care. They have done one-off reports on primary care spend that the legislature has commissioned. And this year, the Washington Academy of Family Practice is advancing a comprehensive bill that would establish a collaborative, measure spending on a regular basis, and again, try to increase focus on this stuff. Finally, we talked about Rhode Island. This is work that I undertook when I was health insurance commissioner. We did not wait for legislative activity. We determined that we had authority within our insurance regulations, because we were told statutorily to focus on affordability, that we had the authority to work with the commercial health plans to measure and then increase the portion of dollars that go to primary care. It's important that when we did that, we didn't just sort of deliver this word. We actually worked with an employer group, a health insurance advisory council, and sort of they took their conditions. So they said, they listed 2 big ones. They said, yeah, the health plans should increase their spending on primary care. given two things. It can't increase overall spending, and I had to verify through rate review that these increases in primary care spending didn't increase overall spending. Realistically, that amounts to a redistribution within healthcare. But the other thing that the advisory commission wanted was to make sure that these increases were not in fee-for-service spending, that the health plans had flexibility to get the money out to primary care providers, but it couldn't just be in increased E&M codes. Now I think that gave the health plans room to innovate. We can talk about what they did with it if you want, but it's also important to note that this is only commercial insurance. This is not focused on Medicaid. So unlike Oregon, Washington, Colorado, this is driven by the commercial side as opposed to the Medicaid piece. And different states will take different approaches. So I think as you folks in Texas think about this, this is work that, again, the Primary Care Collaborative did around what state leaders and stakeholders ought to think about as you make the case for primary care. I think that the question that you were asked right at the beginning is really important. Other than it being the right thing, why are you doing this? And an equity argument might not win everywhere, but I would also encourage you not to overpromise around costs. Primary care providers have put themselves into boxes, particularly with payers, by saying, give us more money for patient-centered medical home payments, and we'll save you money in the next couple of years. That's not a winning argument. The data says that doesn't happen, and it's not a fair burden for the primary care to take on. Certainly pharmaceutical companies don't take that on when they introduce new drugs. They don't promise to save the system money. Imaging companies don't take that on when they do new diagnostics. We're putting in more money into primary care because we think it produces more benefit. It reduces equity, it increases lifespan. The other thing I think is really important when you look at the other states is they had some sort of state champion for primary care. It could have been in the executive branch, like the Colorado Medicaid director, or it could have been in the legislative branch. The Oregon legislation was advanced by a family physician in Oregon. And so as advocates in Texas, think about this, and I'll ask this question later on. One of the lessons from other states is to have champions in state government, particularly clinicians. Clinicians tend to be sympathetic to this, and if it can be educated to advance this cause. Lisa, you want to talk to some other strategies besides primary care spend and legislation?
Sure, and this is really work that we've been doing at Milbank, and actually prior to my joining Milbank, it's over a decade now, and legislation clearly is a very important and perhaps the most important step that can be made because of the footprint, but there are other opportunities that can make a big difference, and you've already started doing that here. That's very clear. So it's important to do measures, the opportunity to really do an evaluation and understand what the spend actually is. I mean, that requires discipline. It requires an investment in resources, but it's very clear it's extremely important. You can't just sort of think that you need to spend more on primary care. You need to actually demonstrate what the spend is and what the inequities are. And then the work that I've had the opportunity and frankly the honor to be engaged with for many years now is around pulling multi-payer groups at the regional level together. We've had chances to work with the Innovation Center at CMS, which has led multiple programs engaging primary care in the multi-payer space to a greater or lesser degree of success. But nonetheless, the march continues, and that those opportunities still exist, and there are ongoing programs. It's very important because this engages the human side of it. It takes the scale down a little bit. And I think that TPCC is an excellent example of that. People who know each other get on the phone or on a Zoom or perhaps in person someday to be able to engage in this work together. And one of the things that we have found especially noticeable is that the regional commercial plans, those that really are homegrown, as it were, there's a lot of energy and frankly sympathy towards the issues that primary care faces, and that can be leveraged very effectively. It can be extremely influential with many of their peers. Next step, please. Next slide. Thank you. Another question you can ask, and this relates back to some of the slides that Chris was showing around Medicaid, is that, what they really can be a source of both energy and sustainability for primary care transformation. So there's leverage in terms of managed care contracts. Like what is the language in those? How do you actually create those so that they provide reasonable services for primary care? Increasing access for a particular population, as they've done in Connecticut with pediatrics, and to some degree also in Rhode Island. Certainly the multi-payer work that you saw, the examples of that Chris showed, but they're in other places as well, in Maine, Ohio. There's lots of work going on there. And as you may or may not know, Texas is in a new innovation center program, a rural health model, a CHRT or chart model, they call it. And that can be an extremely important component in a state as huge as Texas, but with a very large rural population.
So it's time to rebalance things around primary care. And as you think about this and you develop your strategies, Lisa and I would really encourage you to be clear about the problem that you're trying to solve and what your goal is. Are you doing this to address inequity? Are you doing this to raise awareness about the fragility of primary care? Are you doing this to get more money in? These are not mutually exclusive, but you got to understand the problem and the goal. Are you going to play the community health center card, which they have done very well in both Republican and Democratic administrations, frankly, not as an alternative, but as a consolation prize, I guess is what I'll say, for insurance expansion. There might be opportunities there in Texas. Texas is so big, you can call attention to in-state variation. To the extent that the measures that TPC is coming up with and you're documenting variation, that's a real cause of concern. You guys want to be a republic anyway, so you might as well take advantage of that and look at the variation. Be really clear about your payer group of interest. As we said here, it may make sense to start with Medicaid rather than commercial. On the other hand, if you have good local health plan leadership and you've got something to build off your medical home initiative, you can use that as a platform to go forward. Where do you have champions in the branches of government? Go where your strengths are. If you cultivate that Medicaid, that's great. If you've got a sympathetic legislature, perhaps who's a clinician, work with that. So go where the strength is. Too often, healthcare is controlled by what I call the usual 20%, the providers with a vested interest. So what is bugging the other 80%? You cannot solve an employer's cost problem with primary care. There are other much more direct ways to solve a cost problem if you talk about rate setting for hospitals or for pharma or something like that. But there are other things that are bugging people. It may be lack of access to care. It may be confusion about what to do during the pandemic. It may be navigation issues. What is it what's a problem and how can you help solve it? And be careful, as I keep saying, about overpromising to employers. And then there are technical solutions, which I always think are second order. Defining primary care, that can be a difficult thing when you get down into the specifics of it, and the data sources, where it looks like you guys are in pretty good shape. I think regardless of what your strategy, a long-term view, and this probably you can do it in legislation, but you guys have the beginnings of it here with TPCC. You need a place, a commission, a collaborative that is shepherding this. And that's a real strength that Texas has. Places where people are coming together and applying persistent attention over time to how are we doing? Are we making progress or are we not? And all the states that have really gotten into this, Oregon, Colorado, Rhode Island, have these multi-stakeholder, not necessarily run by the government, collaboratives that are just applying a persistent focus, because you better believe that hospitals have that, pharmaceutical companies have that, primary care needs it as well. And these are some of the functions that the collaboratives do. Again, you guys are in good shape. This is work that the Primary Care Collaborative did for us. We asked them to look at how these collaboratives are organized in other places. We've got a citation for the report that they put out. You've got a number of assets in Texas that are really impressive. This coalition of willing that the Primary Care Collaboratives put together, and all of your members there, the folks who are on the call today. You've got really good data, and states legislative support for data that doesn't necessarily exist in other places. That data, other states sometimes use their all-payer claims database. Sometimes they use direct claims pulls from the insurers. Either way, but you need data so that you could go with this. And Texas is in a relatively decent shape. But you do have challenges. I don't have to tell you what those are. I'm not sure that you have identified champions at senior places in the government, and those are really important. That's lessons from other places. You've got maybe this is too strong. We are from out of state. I'm not sure I would say no history as I read this, but you've got to work on this collaboration. And Lisa's point is really important. The leadership in places usually comes from regional health plans. They're willing to step up. Texas has a mature Medicaid managed care structure. There might be opportunities there. You've not expanded Medicaid. That's sort of a bellwether for social solidarity, and primary care in many ways is a social solidarity play. So we have to acknowledge that. And you have a commitment to limited government. We are constantly looking for political diversity in the states that we bring up. And so we're really glad to do this work with you. And maybe we can talk about that. How do you advance this in states with a political and cultural value to a limited role for government? There's a reason why people live in Texas and not in Vermont. No offense, Lisa, and that's because they like it that way. And so we at the fund are particularly aware of the diversity. Where I want to close with this is a little bit personal. I really appreciate the work that you guys do. The fact that in spite of the challenges, you're continue to work on this. I think Billy would be mortally embarrassed if he knew that I was using him. But a few years ago, my wife and I went to Big Bend, and Billy was our guide as we went down the Rio Grande through the canyon. Now, Billy had finally found his home. He was a college dropout. He'd been a fine arts major. He'd discovered rivers, had rafted all over the place, been a river guide, settled in Terlingua with his wife, who was working a bar, and their kid, who was born with a medical condition. They got their kid on CHIP, but both Billy and his wife had no health insurance, no usual source of care. He's a hell of a good guy. We had great conversations all the way around. I ended up trying to give him advice about how to get on the exchange and what might happen with it, but that's no substitute for a usual source of care. And I don't know how Billy did during the pandemic. I think Terlingua was on the ropes during that time because traffic went down so much. But people in Terlingua, the people who are doing this kind of work, deserve a usual access of care. They deserve comprehensive primary care. And so you guys are doing the work in Texas. And on behalf of Billy and the folks in other places, we really appreciate it. And we want to help you as you continue doing this. So I think, Sue, you're taking it from here, right?
Yes. Although it's pretty hard to follow that. It's pretty hard to follow that story about Billy. Really fantastic presentations, and so much for us to think about, and so much to really help guide us. We're just really excited with what we've heard. But so I took the liberty of copying one of your slides, and I understand you said this was from the PCC. This part in particular, and as you all know, and most of the people on this call know, the TPCC, I think, is really looking to move our agenda forward. And how we do that is one of the reasons that we obviously invited you all to talk. But I want to kind of drill down on a couple of things and really try to understand from your perspective how we can leverage primary care to address some of these. And so, Ankit, can I have the next slide, please? Right. So I'm going to talk about my hometown, which is Dallas, and I want to illustrate some of the health equity issues that exist there, and unfortunately have existed for many generations. This is nothing new. There was a recent article just a couple of weeks ago in the Dallas Morning News that really pointed out that in the census tract just west of Southern Methodist University, and if you look sort of in the middle of this picture and you see 75205, that is actually where SMU is. Southern Methodist is a beautiful, beautiful university. And that happens to be where the neighborhood that I live in too. Average life expectancy there is almost 80, it's 86.4 years. 7 miles to the south near the Oak Cliff Cemetery. So that would be in the little like 75241 zip code. The life expectancy on average is 64.2 years. This is 7 miles difference. And this is over a 22-year difference in life expectancy. And again, this is nothing new. Sadly, it's persistent. And the corollary in terms of income is, again, in the North Dallas, the community that I live in, the median incomes are like $250,000. And again, in the 10 southern zip codes in Dallas County, it was $21,000. So again, a 10-fold difference in income. I think one of the most distressing statistics about my hometown is that 21% of children in Dallas County live in poverty. So it's pretty stark. It's really pretty stark. And if you look closely, you can sort of see that there are highway lines. So there's interstate highway signs, and this really validates the whole point of how building interstate highways has really divided in many ways and further segregated our communities. But that may be for a different discussion. Ankit, can I have the next slide, please? And again, similar kind of a thing. So this is a socio needs index map from Dallas County. Very similar type of situation. The darker the zip codes are the greatest challenges and the opportunities for addressing health disparities. So the map looks at income and employment, education, among other factors. So, and also it should be noted that hospitals are concentrated in the northern part of our community. So again, we've known this for over 20 years. We've known this kind of data, the statistics, and it is frustrating to see how little progress has been made, despite the fact that we have some phenomenal partners in our community. Parkland Memorial Hospital is a phenomenal institution, Dallas Children's, they're lifelines, but they can only do so much. They're somewhat limited. So my question to you is really twofold. How can we leverage primary care to address these issues? And how can we communicate the importance of primary care to our elected officials if the message has not been received until now and they see these same data sets? So we're not doing something right, or we're doing something wrong, I guess. We're not making the pitch in a way, pardon the expression, but we're not making the pitch in a way that is being heard. And I think, Chris, you really said this, things like access doesn't command attention like spending. And so what is the message? And Chris, I know you have, and Lisa, you have too, worked with legislators and policymakers. What is the message that is going to help us? And again, Dallas is just one community out of many, but I think it's fairly representative. How can we leverage primary care, and how can we communicate the importance of primary care to the people that can help make a difference?
You looking for a response, Sue? You want to have a conversation?
Yes, it's a question for you all.
Well, from a practical standpoint, to the extent a single legislator or a Medicaid director can make a difference. So to the extent you get to the right person or have the right person in a setting, don't underestimate kind of that personal strategy. Lisa and I have watched, it's actually the same Medicaid director, Medicaid medical director, first in Colorado and now in Washington, just move mountains around the bureaucracy and to raise primary care as a commitment because she cares about it and she gets it. So there is this very kind of personal strategy. The other thing I don't have the data, but to what extent can you produce similar charts, Sue, for rural settings? Can you build partnerships so that this isn't just seen as, oh, it's an urban poverty issue. You know, we're never going to get past that. You have to kind of chunk it down and find ways to appeal to build coalitions, to appeal to it in different settings. So I don't know, Lisa, do you have anything that comes to mind? Those are two, that's not super rocket science, but that's how other states have done this. You know, Washington's got good leadership. And in their chart, they've got a big primary care play. When I say they are a chart grantee like Texas. And there's a big primary care play, and they're being very strategic because they want to build stakeholders in rural settings for strong primary care.
I do think I'll just make a a pitch, because I'm a pediatrician, that I do think that focusing on pediatrics and fairness for access for kids is it's kind of hard to dismiss that. It's like it's saying, if you just say you don't care about the children regardless of where they're living, that's a hard one to defend. So that and I think part of the Medicaid director who you're referring to, part of her success has been saying there's another M in CMS. It's not just about Medicare and the innovations that have come through the Innovation Center. So that opportunity needs to be highlighted.
And
So go ahead, go ahead.
just one other idea. I don't know what the state politics are like, but I've always thought there's great opportunity to build common cause between the primary care movement writ large and community health centers. They've really done a masterful job, not only in advocacy, but in they got results. This side of the VA, they're the closest thing to an integrated primary care delivery system. And so it can be a challenge to find common cause because the health centers are traditionally very focused on their own funding streams. But if you can, it can generate enormous, I think, benefits to build that coalition.
So finding the right person, and there is going to be that person. So finding the right champion, I think. And again, this is just, and so the other part that I was going to talk about that is the healthcare cost, and in our state and others as well, but ours in particular. And we're certainly not proud of it, and it's something that worries us and really occupies a lot of our attention and has for years, is how to address the growing need of the uninsured or underinsured in Texas. And so this is from I'm proud to say, this is from our own Primary Care Consortium data dashboard, which shows just a little infomercial here, shows all the 254 counties in Texas, and thank you, and lots and lots of information, a lot of rich information about the demographics, the health needs, the health care workforce, et cetera. So in Dallas County, 21% of the uninsured adults are uninsured, and that's probably about 2.5-3 million people in Dallas County. So do the math. And again, poverty rate, you can see. So the problems are large. But I really love I love the idea about the federally qualified health centers, and we have certainly talked about that. So it's really good to hear. And we have good relationships with the leadership of our local organizations there. Connecting to a common cause and finding the right person. Children, absolutely, Lisa, that is so true. How can you not, right? How can you not, even if you're a grizzled legislator that is, heard all this before, how can you not respond to children? So I like it. I think that's excellent advice. Can I have the next slide on, please? Okay, so I'm glad to know, Chris, that you have been in the Big Bend country. So you can now appreciate the vastness of the Big Bend country and the very sparse population of the Big Bend country. And this is Dr. Billings. This is Adrian Billings. Adrian Billings is a family physician. He grew up in Del Rio, Texas. He went away to medical school in Galveston and wanted to come back to Del Rio, but there were not any, health service opportunities there. So he ended up in Alpine, Texas, which is kind of the gateway to the Big Bend country. And I'm going to talk more about him in a minute, but Lisa, you said something about, or one of you, the two of you said something about, can you develop charts to show the same kinds of data about rural Texas? And unfortunately, yes, we can. We can do it very easily, and they are very, very, very graphic in the sense of, we love to, in Texas, we love to talk about how big our state is and et cetera, et cetera. But there are many statistics we're not proud of. One of which is that there's 35 out of the 254 counties have no physician at all. So think about that. And additional 30 have one doctor. And so people like Dr. Billings, who come back to kind of where he grew up and has decided that he wants to make a change. So he leads a federally qualified health center. As a matter of fact, he's the chief medical officer for an FQHC in Alpine. And he has, over the time that he's been there, he has seen over 300 medical students come through. He has hosted them and about 50 residents to his clinic. So you wonder, how are people going to get the bug, if you will, for rural healthcare? And it's through people like him, right? And, you can have the money and you can have the support, but if you don't sort of have somebody like him to open your eyes and go, wow, this is really an interesting way to live, and I want to live in a rural community. So kudos to him for what he's done. The other thing that he has helped do is he has helped establish a 2-year rural training track for family medicine residents from Texas Tech Permian Basin. And so I think there is some good news actually in the rural area. And Lisa pointed some out, the CMMI project. And also, we're really proud to have in our state the Texas A&M Rural and Community Health Institute, which we affectionately known as Archie. And Archie is really a leader in finding solutions for healthcare needs of rural Texas. And it does appear that the Biden administration will invest over $1 billion to address the shortage of primary care docs, nurses, and behavioral health clinicians in rural areas through scholarships and loan forgiveness, et cetera. And there are also a couple $100 million will go to the teaching health centers, graduate medical education. So again, is that going to solve the problem? No, but it feels to me like there's so much more recognition, I think, at the national level and at the state level, the magnitude of the problem, as you mentioned, in many states that have many states that have a rural component, but certainly in ours. And even though we have a lot of doctors in our state, they're maldistributed, right? So the physicians and nurses, they want to practice where others do. And they want to cluster in urban and suburban centers. But I guess being an eternal optimist, I see and learn about people like Dr. Billington. I think, I think we are making some progress. It's going to take time, but those are the stories, as you say, that we tell our legislatures, that we must tell our legislature. So one of the things you said, Chris, a couple of times in your slides that I thought was important was that innovation itself is not going to get us out of this, right? Innovation alone is not going to solve the primary care thing. But I guess I would think that innovation and properly utilized and directed resources together, combined, along with vision, really may help us find our way. So, and that is not as much of a question as just to say how important rural medicine and rural health is in this Texas. So, but any comments are certainly welcome.
I will tell an anecdote, Sue. First of all, I remember being at a I think it was a managed care meeting. It's when I was working for a Medicaid managed care organization, and I met some insurance executive from Texas, and he looked at me, he says, "Rhode Island, we got ranches in Texas bigger than you guys." So I've always been humble about sort of the approach, appreciate the size and the diversity of Texas. I think that I'll go, how can you, one, I agree completely. The innovation, maybe I overstate that a little bit. There's policy innovation. We certainly want to encourage that, but we don't want to think that CVS and wearables is going to solve our primary care and population health issues, or the stuff in Dallas that you're talking about. I think that building a bridge from the Dr. Billings and what the great things that he's trying to do there, and the situation that you were describing in Dallas seems really important. How can we, to the extent you can create, and it might be around workforce development, you can create policy initiatives that unite the urban concerns with the rural concerns. Lisa was talking about pediatric Medicaid rates, something that's a little bit hard. And I saw a question in the chat, but really holding it out there, what portion of Medicare is Medicaid paying for primary care or for other services? And I think you can't expect commercial health plans to cross-subsidize everything about poor people's care. And primary care is a pretty good place to start to reduce that cross-subsidization. If you can get Medicaid to pay its own way, it's going to buy you pediatric access, which just seems so important and frankly so much cheaper than other places where it could be spending its money. So I'm linking two thoughts there. One is building common cause with the urban and rurals, and building on Lisa's suggestion around Medicaid access, which comes down to Medicaid rates. Medicaid can improve their participating physician rate if they can raise the rates that physicians get paid. And primary care is the first place to start.
Right. Excellent. Ankit, did you have anything that you wanted to add at this point?
Oh, I think this is definitely a hard act to follow. It was difficult to begin with Lisa and Chris, and then Sue, you just took it a notch about. So again, I want to be respectful of everyone's time, and I think my job is a relatively bit easier today, but it's going to be a tough act to follow. I do want to utilize the remainder of the time that we have today to answer a couple of questions that we have had from the audience, and apologies to the team for not following the memo. So if you have any questions, please use the Q&A option at the bottom of your screen or at the top of your screen where you have your tab. But there is a Q&A tab. Use that to enter your questions. I'll do my best to cover all of them. I already see a few that have popped up. And I believe this is a good question, Chris, for you and Lisa to answer, and then Sue would be helpful to see if you have anything additional to add. Amongst the commercial payers who may not have a long-term financial horizon per se, especially with members and transition as an outcome per se, how do you frame arguments about why focusing on primary care is important? And I think that you stressed on the importance of not overselling the financial ROI aspect. This is maybe one of the factors, but I think very interesting question. Would love to hear your thoughts.
So Lisa, why don't you go with that? What's kept the commercial payers at the multi-payer tables that you work with?
So I do think there's a strong sense of community-based commitment that especially seen in the plans that are either community health plans for some reason or Blue Cross Blue Shield based organizations that have direct personal connections to the communities in which they work and live. And that's not necessarily something that's replicable around the country, but it is important. And so there's a sense of personal commitment and personal responsibility in that regard. I also think there's some peer pressure that this is seen as the right thing to do. If it's supporting primary care, it's very hard to look at that 5% number and say this is fair. It's just not. And so that the willingness to try different things, whether it's value-based payment or capitation or various other options, that's important too. And I do think that there's an element of wanting to, and this is really highlighted in the last year and a half in the pandemic, of trying to make the case for primary care needing to survive the ups and downs of the economic roller coaster that we've been on, and that primary care specifically has been on. The devastation in the early months of 2020, where people stopped going to the doctor, there were no options. Everybody had to very quickly move to far from perfect technology around telemedicine to be able to see their patients, and that just illustrated in vivid terms how poorly structured primary care was and is. So those pieces, I think, are felt again by people who live and work in the communities in which their businesses are.
Lisa, should we name names? Is it fair to say that in the multi-payer work that you've done, you've seen stronger leadership and participation from the regional plans than from the national plans?
Yeah, I would say that's the case. And it's not 100% of the time. There are a couple of national plans that really did step up to the plate, but they have a national business plan. They don't have an individual state or regional business plans. And so it becomes very tricky for them to do things differently in different places, which I sort of respect, but also frustrates me.
Thank you both, Chris and Lisa. I'm going to again encourage our participants to enter any question, but I've been, as Chris, I was walking through your presentation, but also as you're putting a lot of things into context with all the different data points. One of the critical challenges that Texas certainly faces, no matter your data sources, is our health or our uninsured rate, whether it's for the total population or particularly for adults. And that happens to be a key priority area where there is a lot of convergence, especially from a stakeholder perspective. And when you think about trying to find a Texas solution, which happens to get some attention than Medicaid expansion, how do you leverage the role of primary care as part of advancing a Texas solution to addressing our uninsured problem?
Yeah, if I understand your question, Ankit, I think one certainly defensible stance for primary care is to acknowledge the fact that Medicaid expansion will benefit primary care. That's certainly been the role of the hospitals. The hospitals have been in states are the strongest advocate for Medicaid expansion because it reduces their uninsured rolls. I imagine their uncompensated care costs associated with for independent primary care practices or non-health center practices that would be reduced with expansion. You would get more paying customers, and that's always a good thing. You would get better population health. So, this is not advice, but I certainly get the logic that places a priority on legislative action around Medicaid expansion. And the role of primary care in that sense is to be a good member of the coalition while kind of building primary care's identity and value independent of that, so that when expansion happens, there's big momentum for designating a usual source of care. You want to be there for any changes in Medicaid management. If and when expansion happens, maybe there are program changes that can happen at the same time. I mean, I used to say that my goal was to get sort of the primary care its own slice in the healthcare expense pie. Maybe I've added one more thing, which is that we could get everyone to agree that selecting a usual source of care should be almost a condition of your insurance benefits. That's really, it freaks people out because it smacks of managed care and stuff like that. But insurance should not be and this appeals across the spectrum. Insurance should not be a license for people to bounce around the healthcare system. And choice, take anyone who's ever tried to help an elderly loved one select a Medicare plan. You can have too much choice. We can have too much choice of medical services. And so this notion that people should have a usual source of care, I think, is very powerful. So what I'm suggesting is that there are ways that you can both advocate for expansion, be part of the coalition, but then have the value of primary care recognized as part of that. That might be, like Sue, overly optimistic, but I think you can do it because you've got the real setup with pediatrics. You've got the, I think, real setup with folks with chronic conditions. They're dying for advanced primary care that can help them navigate this. Literally dying.
Wonderful. I think there was a question in our chat that I missed, but I think it's more of a response, and I'll take the liberty to respond to it, and we'll invite Chris, Lisa, and Sue to chime in. It was more of the question on what % of physicians do not accept Medicaid. I think when I've looked at that data point, it's one of the resources, Chris, you mentioned in your presentation, which is the Commonwealth Fund, and it happens to be a quarter of our physician population here in the state that does not accept. However, I may be off since it's not something I've looked at. So Chris, if you have a different, or if you would like to.
Helen Davis from TMA just confirmed that that's their latest data. So good. I mean, not good, but yeah, you got your data right. There you go. So. We have not had, there has not been a fee increase in Texas for over 20 years in Medicaid. And so, and I don't want to bring us all down about this, but as you might suspect, there is very significant political turmoil, I guess, involved in moving Medicaid forward. So we really, as the consortium and as others, TMA and others, have sort of made it like, let's have a Texas plan, right? Let's have a Texas plan and maybe not use the M word or something, even though that's probably what we all mean. But so and to be quite fair, we got closer the last session than we have really ever before. And so I think there is increasing recognition that something really does need to be done. And so we actually tend to be, I think, agnostic about how it happens, but we also know, we look at the numbers, we know that something has to happen. But something has to happen to give cover, if you will, to our elected officials and legislature. And we've done a lot of work on that. TMA has done a tremendous amount of work on that, and we certainly have chimed in. So yeah, I think everybody recognizes it's just how you get there in a politically palatable way, and that's a work in progress.
You know, one that not so much for advocacy for the Texas plan, but just as a way to kind of build primary care's identity. If you have access to reliable information just on how much primary care physicians get paid by payer type, what's the Medicare for of Medicare for commercial and for Medicaid? You know, you don't have to put actual dollars out. You just index everything to Medicare, and if that's a big disparity, whoever's on the outliers has to answer for it. You're just putting the data out there. And if Sue, you're 20 years, that needs to be pointed out and called attention to. And then understanding what sometimes managed care can be a black box. So understanding what the relationship is between Medicaid fee-for-service and on all, you know, you don't have to name plans, individual plans, Medicaid managed care plans, just so that data is, and that sort of payment information is really important and often gets hidden.
Well said.
Yep.
Sue and Lisa, Chris, again, all three of you, thank you so much for your time and expertise for today's discussion. It's been informative, to say the least, but also inspiring and encouraging for the work that lies ahead of us. And we certainly will be going back to utilizing a lot of these data points and resources. But particularly, I want to give a shout out, Chris, to the questions you've asked us to be thinking about. That like we cannot be everything to everyone, and we cannot be successful in all pursuits at once. So it's a step up approach, and persistence is the key. So a lot of wisdom in there, and that's going to be very useful for us for where we are and where we need to be. I do want to be respectful of all of your time. So just want to use the next few minutes for some announcements and some housekeeping items. But before I do that, I just want to express again my gratitude and appreciation, Chris and Lisa, when I first reached out or was on the Zoom call to plan for this webinar. Really a fan for the last several years that I've tried to learn a little bit more about primary care. Milbank Memorial Fund is something that I really look up to and enjoy each of your information and publication that comes out. Also, this is part of a growing movement, and as we have heard clearly today, this is a pursuit for the long run. We need to be persistent. We'll only grow stronger and be motivated if we have more friends and partners to join us in this journey. So please visit the consortium website, subscribe to our newsletter to learn more about everything that's happening at TPCC and how can you be a part of it. I would be remiss to not recognize an amazing team that actually does a lot of the work, and Sue and I get to just be the face of it. So we don't take that for granted, but really a huge shout out to our team to help us do this and make TPCC an exciting journey. So with that, again, appreciate everyone joining, but particularly our collaborators and friends at, if I may say, Chris and Lisa, just using some liberty at Milbank Memorial Fund, for really sharing your experiences, your wisdom with us for this critical journey we are on, and so of course for being an amazing leader and partner to work alongside.
It's our pleasure.
Thanks everybody.
Thank you very much. Keep up the good work.